and welcome to another Top Doctors Online interview where we speak with one of our leading specialists. Today, we're very lucky to be joined by Mr. Jonathan Bull, a highly respected consultant neurosurgeon and spinal surgeon, to discuss sciatica, a condition which can cause very significant pain and discomfort. So welcome, Mr. Bull, and thank you for joining us today. Would you like to introduce yourself and tell us a little bit about your background and your areas of expertise?
So, as you said, I'm a consultant neurosurgeon with a principal interest in spinal surgery or complex spine surgery. I work in the NHS in Barts Health in the Royal London Hospital in East London, and my private practice is typically London Bridge and the Cromwell Hospital in West London. And I've been a consultant for about 10 years. And I trained in London as well as also a European Association fellowship in Munich. And also did a fellowship between Stanmore, Royal National Orthopaedic Hospital, and the National Hospital for Neurology and Neurosurgery.
Thank you very much, and we're delighted to have you with us today. So as I mentioned, we're going to be discussing sciatica, which unfortunately is a relatively common problem. So to start off, Mr. Bull, could you tell us exactly how sciatica is defined?
So typically sciatica would be, it's a symptom rather than a diagnosis, and it will be usually due to compression of a nerve root, typically in the lumbar spine, where you get pain in sort of lower back, buttock, typically passing down below the knee, often down into the calf or the foot or the ankle. It can just pass down to the thigh. Sometimes it occurs on one side. It can occasionally occur on both sides. Often when it occurs on both sides, it's potentially part of an emergency presentation called Aquinas syndrome, where you have compression of a large group of nerve roots. And that can have bladder and bowel complications as well. But the more common presentation is usually unilateral, so single-sided, lower back and leg pain.
Thank you, Mr. Bull. So just how common is sciatica?
It'll probably affect about 10 to 40% of the population at some point. So lots of people will have it, but often people may have recurrent episodes. It's a relatively common presentation. It's usually self-limiting. It usually doesn't require much more than analgesia, and the natural history of disc protrusions that cause sciatica are that they will resolve with time. Often you find that physiotherapy, exercise, and analgesia will be helpful, and typically inactivity. So often people say they have back pain, they take to their bed. Often that will actually exacerbate the problem, make it worse, and then you end up with much more stiff muscles, and you don't maintain the range of movement that you need to ideally offload that nerve, which is being compressed by typically a disc protrusion.
Okay, so many people may be wondering, I know you've talked about compression of nerves, but what actually causes sciatica to occur? And can it be linked to lifestyle factors or things like stress or anxiety?
Well, what typically happens is that there's a genetic predisposition, and the pattern is that you'll get wear and tear change in the intervertebral discs, the soft squashy tissue between the bones in your lumbar spine, the base of your spine. That's a normal process. People will show it at different rates. You don't typically see sciatica very commonly in people under 20. It's commonest in sort of age groups about 30 to 50. What happens is the disc, as you get older, will gradually dehydrate. And as it dehydrates, it starts to bulge outwards. So, for example, people are often they will be taller in the morning than they are at night because the discs are hydrated overnight when you're lying flat, and then when you stand up, they're under pressure and they gradually dehydrate. That process becomes more pronounced as you get older, and sometimes the covering of the disc wall, which is a hard fibrous structure with a soft sort of porous center, the outer wall will start to weaken and fail, and then either it will bulge out more, or you'll get a disc that pushes out through that wall into the spinal canal, putting pressure on a nerve root. Often it will start with pain in the first instance because it tends to affect the small fiber nerves preferentially initially, due to the compression, so you get pain, and then it typically give you numbness and then eventually weakness. It doesn't always follow that pattern, but that's quite a common pattern. In terms of lifestyle factors, there's evidence suggests that, for example, obesity, so high body mass index will predispose to it. There's a significant genetic predisposition, so some people are just more likely to get it than others. Some people can make the situation worse, like, for example, heavy weight lifting. So a lot of people who do cleans and deadlifts with large weight and their technique is poor, that can lead to disc prolapse, disc herniation. And generally, slim people less likely to get it, but it's not a dramatic difference. And generally, being physically active is helpful because it strengthens the muscles, especially core muscle strengthening, things like yoga, Pilates, very beneficial. So they will then aid support for the spine, and that reduces, or theoretically can reduce, the risk of having a disc herniation. But partly it's just a natural process that will happen over time, and that's why people will have it. But often it will be self-limiting and it will improve of its own accord.
Thank you, Mr. Bull. So obviously we're talking about quite significant discomfort here. Is there actually any way to prevent it? And what are the warning signs that a person may develop sciatica?
Well, generally physical activity, people who undertake Pilates and yoga potentially may be better off, but better core muscle strength. That's, for example, you talked about stress. People particularly who spend a lot of time sitting at desks, there's evidence to suggest that, for example, using a standing desk is helpful because you repeatedly change from sitting to standing, which means the muscles are more active. Again, weight gain is a significant issue. And there are other causes. I mean, sometimes you can have the pain secondary to other more sinister effects. So sometimes you can get the pain secondary to like a fracture or secondary to a tumor, but that's very, very rare.
So what are the warning signs that a person may develop sciatica?
Well, typically you'll get normally lower back pain first, and then you may get slowly progressive pain discomfort, typically heading down to the buttock, the back of the thigh, and then it will progress down the leg. I mean, that's the main warning signs. The principal caution is that it's not in of itself dangerous if you get pain. If you then start to get sensory disturbance, you again typically wouldn't operate for altered sensation. But if people get weakness, then that is an indication potentially for surgery. You can manage the weakness conservatively with exercise, physio, potentially diagnostic therapeutic injections, so epidural and facet joint or medial branch block injections. And that may, again, ameliorate symptoms. But typically, if you have weakness that's persistent, that's the sort of situation which you may end up needing surgery. So
what complexities are involved in the treatment of sciatica? Is intervention always needed?
No, generally, typically you can manage it conservatively. Most cases will resolve with conservative measures, as we discussed. There's a concern that if you start to get worsening leg pain and weakness, you may also get blood and bowel disturbance, which is the cauda-equina syndrome we described, and that is an emergency, and people should attend A&E if that were to happen. It's rare, but when you see a surgeon about sciatica, you'll typically be cautioned about that. And that will need an operation to decompress, to remove the disc that's likely causing the symptoms. One of the complexities is that you have to decide whether or not you want to continue managing something conservatively. So someone may have pain, which you can control with medication or with injections, but they may also have weakness, and it's a question of how long you leave it for that weakness to improve, or for the disc to reduce in size to allow the weakness to improve. Typically, if the weakness starts to get worse, then there's more of an indication to operate. But then there's a decision that if you've got a stable weakness, which is a mild degree of weakness, how long do you wait? There's evidence to suggest that perhaps the longer you leave it, the less likely it is to recover, but it's not very clear how long you should leave it and how to quantify that risk. So it's a conversation you should have between the patient and the surgeon to decide what risk they want to tolerate and at what point they decide to have surgery.
Okay, thank you so much, Mr. Bull. And just to close up now, for people who are experiencing sciatic pain, is it possible to remain active and do exercise? And what recommendations would you make in that regard?
So I would suggest that there is good evidence to suggest that you should remain as active in terms of, so swimming, cycling, walking are all beneficial because they're not particularly heavy weight bearing activities. Running can be more problematic because of the recurrent impact. Things like yoga and Pilates are very helpful. The standing desk interventions for work, trying to break up the period of time you spend sitting or standing is also an option. You would probably suggest that people avoid things like heavy weightlifting, like carrying very heavy bags, that sort of thing. But inactivity has been shown to make it worse. So yes, you should carry on with the normal activities. And things like, for example, if you're used to going to the gym and doing heavy weights, you may be better change into a lightweight, higher repetition program or doing a lot of body circuits. They're also beneficial. And also regular stretching, morning, evening stretching. And you can also look up lower back stretches online. and a physio, osteopath, or chiropractor will also be able to provide you with an exercise program that you can do. In addition, often patients will say, I don't like using painkillers and it masks it. But actually what the painkillers are doing are hopefully allowing you to be more mobile and active. And what will tend to happen is, as the nerve is irritated, the joint that overlies it, behind it, will get stiff, and the muscles overlying it will also get very stiff, and you lose that range of movement. And the injection and also painkillers are designed to provide opportunities to be able to move despite that pain and return that range of movement. And as you, for example, lean forward, you tend to open up the space where the nerve sits. And as you lean backwards, it closes it up. But that range of movement is critical to provide the nerve with some degree of relief. So the painkillers are worth taking. And if you can control the pain, you can maintain activity, and you're aiding the recovery. So it's actually helpful. So despite people's general resistance to taking painkillers, often it's beneficial.
Thank you so much, Mr. Bull, for sharing all of that information and your expertise. I'm sure it's been really, really useful for anyone listening who's been affected by sciatica. Many thanks for joining us. And I'd just like to remind anybody who is suffering from sciatica and would perhaps like to discuss their treatment options that they can schedule an appointment with Mr. Bull by visiting his Top Doctors profile. You can find us at www.topdoctors.co.uk. Many thanks again, Mr. Bull. Delighted to have spoken to you today.
Thank you.